Thank you. And questions for this terrific panel? Go ahead, Sherry.
Kristen, you mentioned the importance of community engagement, and I'm wondering if you have ideas about who the audience should be for the leading indicators work and what the rationale for choosing that audience is if we're trying to move change.
That's such a great question, I think a really central one, because if the leading health indicators are meant to guide the action, for instance, of the Department of Health and Human Services, that's kind of one thing. But if it's meant to motivate communities to create more healthy environments for their people and to motivate people to take actions that are healthier for them, I feel like it's like everything is different then. You know, I think many fewer indicators that maybe get at the underlying causes of premature mortality, like smoking, poor diet, exercise, alcohol and drug use, things like that, like kind of the underlying leading indicators, leading causes of death. If you're trying to focus on communities, whereas if it's for the government itself, I think that it can be completely different. It could be organized maybe by the way in which the department itself is organized. You know what I mean? But the problem, I think, comes when indicator sets are organized by the way in which they're managed kind of by the entity rather than experienced by people on the ground. So I guess what strikes me as really important is just to be super clear who the audience is, or alternatively, to recognize you have different audiences, but to create different products for them. Like, don't think the same product is going to be great for everybody. There might be 5 key audiences, and each one of them might need something different. Yeah.
Here with a question for Tom. You mentioned cascade versus nesting measures, and I'm just very interested in why you have that concept. I can think of, in the experience we have had in the operating of a health system in Minnesota, develop measures of preventive services up to date, or health behaviors up to date as a single measure, which is a compound measure of multiple measures, and yet it's each one of those separate components has its own constituency and in some ways common versus different sorts of avenues of action. So are the nature of your nested measures just a sum of the individual measures that make up it, or are they something different in terms of character when you're thinking about kind of capturing a component of what might be important as a leading health indicator as opposed to a more detailed component you might otherwise measure in, say, 300 or 1,200 measures or however you have. And Tom brought this up, but I'm interested in anybody else's point of view on it.
We actually have several types of logic that we built into that because of that issue. One of them we have truly, I'll just call them we have more than that. One of them is we do a very simple thing is we just do subpopulation data for it, just so that, oh, if this is smoking for overall, here's the smoking by education level, here's the smoking by. So we do that as one set we build in there. We have another type of measures we actually put in which the measure is a true summary one, which you take the 5 or 6 components and mathematically roll them into a larger number. And we do that for some measures. Immunizations, we do it for like risk of social isolation. We also have a relationship built into our system where we have related measures, so that if you're interested in this, you ought to also be interested in this. So that if you're interested in obesity, you ought to look at cancer rates also. So we know that by literature, they're showing and be connected. And we have found that people coming to our website don't know all those relationships that we kind of take for granted after you work for the data for a while. And so we do have related measures that not at all involved in the add up, but are just, they're connected based on the literature. So those are kind of the 3 ways we tie measures together on a website or on reports to kind of nest them together in different ways. We're also exploring just getting similarities, and we will be probably next year or so, by just topic area. We find people coming in that don't know all the language that we have for measures, but are kind of interested in, they have an entry point that's different. They don't know what the general categories names are. So we're doing some work where we can actually branch them and let them figure out measures fit in next to this that are in the same topic area, because we don't name them the same. The classic example is we have smoking rate and we have tobacco use. Well, a lot of people may not search those two words together. And so we were also building them into topic areas so that they get into that area so it becomes friendly that way, so that these things tie together that way. So we actually have 4 ways of tying our measures together for them.
Martha, and then Jonathan, and then Paula.
Thank you all very much. In I think around 2011, the IOM had a report on measurement for improving population health, and that committee heard a lot of discussion about the need for limiting the number of indicators because so many were blooming that people were confused. And they heard also that it would be ideal to see measurement that could track from national to state to local. I was interested by Kristen's remark that sometimes you see different things, by using different measurement sets, you may see, in fact, some confirmation of what's going on, and I get the idea of having a rich set. But as we think about the leading health indicators, I wonder if each of you might comment about how important it would seem to you to choose them out of sets that could be available at local and state levels as well as national.
So I guess I would say that it's pretty important. And the reason I'm thinking that is we have done some work about sort of domesticating the Sustainable Development Goals. And one principle that we've used in terms of identifying proxy indicators for the Sustainable Development Goals is we have required, like the ones we've picked, we have a dashboard on our website. So the ones we picked, you have to have it down to at least, I think, the county level we've chosen by state and by county. And then we've prioritized indicators that can be disaggregated by race and ethnicity and gender. So that has been kind of our criteria. So that's limited some things. So for instance, particulate matter, we can't disaggregate that by race and gender, things like that. But that's why we use, say, median personal earnings instead of household earnings. So we can disaggregate by women and men. So I would say it's really important because, like the Sustainable Development Goals, basically like any kind of goal-setting exercise, you're only achieving the goal when you meet the goal for everyone everywhere. To have it as an aggregate to say, okay, California met this goal, it doesn't make a difference if huge populations are being left behind. Like the U.S. has already met the maternal mortality goal for the Sustainable Development Goals. But when Black women are, so many times more likely to die on childbirth than white women, then obviously we haven't met the goal as a country. So I would say it's super important to do that.
I mean, we only have to, we work primarily with trying to influence state, if you will, work with states. So for us, our product is not important to go below that. However, the most common question we get when we work with states is, what's your level down at at cities, counties, zip codes, congressional districts? So I think it's very important to be able to go down there because I don't think I've done an outreach thing yet that somebody's not asked about what level can you go down with on the data, because they need to drive it. Even at the state level, they want to know where they need to focus, because for them it's a geographic disparity issue. So where do we need to focus?
Exactly.
So I think it's very important.
Jonathan.
Hi. Go ahead. Sorry.
Okay, Marjorie. Sorry, did you want to respond?
Oh, well, I would just add that it is my hope, and I have this bias, that Healthy People 2030 will speak to the local change maker, and so therefore it's important for local data or county level at a minimum to be able to track what these leading health indicators look like in a local context. It is, I think, something that's been stated in one of the previous panels that what's happening and the progress that we may be making as a nation may not be a shared experience when you think about the county level. So from my perspective, it is one of the most powerful ways to make Healthy People 2030 a valuable tool for the progress of our health.
And I just comment on the responses. I personally have used all three of the data sets that you've had to respond to questions that communities have for me about when I've had the opportunity to go to them about how they can be healthy. And you get something from each focus and each level. But I think the participants realize the interconnections. And what I found profound in Kristen's comments is that down to the census tract level simplicity that you're talking about. And then reflecting upon Donna Bedian's sort of framework for quality in healthcare, structure, process, and outcome. It seems like one of the fundamentals that we're not thinking about is the interrelationship of those variables and the simplicity of the message and how combined data sets can really tell you a lot more. So combining the Measure of America data with the county health rankings data and using some interpolation methods which are sort of perhaps questionable a little bit from really rigorous methodologists, you get a lot more information than you do from looking at any of these reports singly, in my opinion. So my question would be, how important is that as a variable in terms of the structure, the infrastructure recommendation in terms of the structure of the information, not just the data itself or the subject, to an effort like Healthy People 2030, in your opinion?
I think the difference in reports reflects who our audience is different. So I think the more important that you know who the Healthy People 2030 audience is and who you're directing it toward will mean how you can better structure. Because I think the America's Health Rankings is structured to a certain audience. Yours is structured to a slightly different audience. Marjorie's to a different. So I think where you're seeing that difference is the fact that we're all looking at audiences that are slightly different. So I think the way it reflects into the HP 2030 objectives is, so exactly who are you trying to set this data set for? And that will then, I think it's important because every audience has a different way of looking at it, different need for it. And I think that's what drives it, is the difference in audience that we're driving for.
Thank you. Really nice presentations. And I'm actually following up on, we didn't plan it this way, but following up on some of George's comments. I started worrying about when there was overlap in measurement. Say, you have state level measures, IHME has state level measures. For the county measures in particular, IHME uses a particular kind of imputation approach. And I'm guessing, Marjorie, although you didn't talk too much about it, that if you're worried about suppression rules, then you're likely to have very noisy data for certain years and certain counties. How well do these match up? Like if we wanted to adopt a measure, it would be nice to not have to have a measure that was consistent with other measures or some kind of combination.
I'll start, Marjorie, you can finish in. Because we try to sit down every year with county health rankings and harmonize our measures wherever we can. So we're trying at that level to make sure that when people come into it, they see our rate, they see that rate, and they can make the connections type of stuff. And that goes the whole way back just to the definition. It is one of the most frustrating things coming across is you'll see the same name and you read the definition and they're measuring something totally different. I mean, so I think we are trying to harmonize it, recognize the difference. There is data problems when you get to different areas that you can't resolve, and we're trying to be very clear where those exist. But I think a lot of us are at state, we don't have to worry about. We do not estimate any data. Ours is all.
It's all just right.
It's all right there. If we don't have enough data, we just suppress it. For like subpopulation data, stuff like that. Except for someone we do for maternal mortality, we went to 5 years of data to do it in order to report it. So we try to keep away from estimation just for that reason, to try to keep it very strict and set.
Has anybody ever said, well, gee, you have your state measures, but these people over here have a different measure? I mean, how much sort of agreement is there among, there's this sort of industry, but there's more than one group of people doing state level data. Are they generally, do you sort of scratch your head and say, what are these people doing who are doing these measures? Or are you all kind of singing? Are you all harmonic?
I don't get much of conflict. The few times I've got it, you kind of ask them, so where was that data from? I mean, because I think we all have fairly high standards where we're pulling data from. I worry more about the poll of 800 people out that some newspaper did that totally predicts something type of thing. Those things that are really spot type of things going on, that's the more I get things about. These people come out with this one-item surveys, 3-item surveys that are done that are not representative, but somebody pitched it. You know, that's more I get than do you agree with County Health Rankings or Measure for America, or anybody else, or IHME. It's all those publicity polls. Or where we get our conflict is, why do you show this and they say it's this? That's where I get the conflict is, and that's not hard to discredit.
Yeah, so we'll rank states by well-being, and then a reporter will call and they'll say, but, the chambers of commerce have just come and they're basically the opposite. And we're like, well, yeah, that's true. But, what are they measuring? Or they'll say, this other place got such a higher, this other poll got such a higher ranking, and it turns out their measures for well-being were short commute and nice weather. So, that's great, short commute and nice weather, but it's different than life expectancy, median personal earnings, and educational degree attainment, So as long as you can explain what you're doing, then I think that, it's fine, yeah.
Marjorie?
Yeah, I would just offer that it's been our experience that data fluency in general among end users is relatively minimal, and that it is all the more reason why I would wholeheartedly underscore the recommendations that both Kristen and Tom have made about simplicity and just trying to be as transparent as possible using the existing data. I think what it comes down to is a rub between trying to provide the best available information that you can, which at times may mean using small area estimation or multiple imputation, but at the same time being able to communicate that information and that the end user understands what it looks like, what it is, and can relate to it in their community context. So we find ourselves in that interesting polarity all the time.
I want to add one thing, George. We are communicating less and less with reporters that know anything about public health. And that is so instrumental in making things simple and stuff like that. There are just, the knowledge level is not there in the media that was just 5 or 10 years ago. And so confusing definitions, things like that is, there's people that don't know the difference between an 800 poll survey and birth is at 400,000. They don't get that, so.
Dushenka? Sorry? Okay, Paula.
Thanks so much for all your great work and terrific presentations. Just been very, very exciting to me to hear about all your work. Couple of questions, both coming from the fact that I'm a demographer by training. So I heard you all talk about the importance of having measures that are simple, plain, easy to communicate. And Kristen, I was really surprised you said life expectancy was one of them, because that has not been my experience. Life expectancy is a synthetic population level statistic. I mean, you know how it's computed, and there's all the, and echoing what we were just talking about, there's all these now online surveys you can take. Have any of you done that? Take it, what's your real life expectancy versus your chronological age? And there's just a lot of BS around there about life expectancy. Is it really, or do people really understand what those metrics mean at the county level, or the ways in which you're using this really important metric of life expectancy? And then I have another quick question.
Yeah, they do. I mean, I think that they do more than, if we say how long a baby born today can expect to live if the prevailing mortality patterns continue, of course, his or her lifetime. People think about it for a second, maybe they have 1 or 2 questions, but they get that. And also the term life expectancy is sort of out there in the ether. So even if people think it's the age at which you're going to die, or the age at which people are dying today, which isn't exactly right. We're not saying age of death today. They understand it enough that it's meaningful to them, I guess.
Okay.
Yeah.
Great, thanks. And then to follow up again, a demography sort of question. Clearly, there's a lot of focus on mortality, morbidity statistics, I haven't heard anyone today talk about fertility, which is another really important at a population health level demographic process. So have any of you thought about, do you include, and I just haven't heard it or I'm not aware of any kind of fertility statistics? And I'm not thinking like, birth weight, infant mortality, those are important things, but the total fertility rate is the corollary to life expectancy. That's really important to think about when we're thinking about population health and trends, or even something like the ability for women to plan time and space, their reproductive, choices, things like that. Any of you working on that?
We don't measure fertility. It's tough. One of those, I think Marjorie mentioned one of the criteria is it's rankable. So is higher better and lower worse? Or how do you exactly rank that? So we don't have fertility at all. As for family planning, we actually, in Health of Women and Children, we do have a measure from Guttmacher about availability of public services for family planning. And we may have a second one from them also. But I think we have definitely addressed the family planning resource issue type of thing. And also we have intended pregnancies. That's the other one we have. So we have direct that way, but not fertility.
Yeah, we also don't have total fertility by race and ethnicity or anything either. And it's funny because internationally, of course, I worked at the UN for a long time. That's a statistic I'm very familiar with. But for some reason, we don't have that one. So I'll think about that. We do have every indicator we can find about women's ability to choose to become a mother or not, and when and if and all those things. So if we're using data from, say, the Sonoma County Department of Health or LA County Department of Health or whatever, we use whatever we can that tells us the most possible. And in terms of recommendations, I was running over, so I went through my last slide, but my team, so right now we happen to be a team of 7 women. We're looking through all of the indicators, and everyone was saying the same thing, more on intimate partner violence, more on abortion services, more on reproductive freedom of all kinds. So I would, of course, advocate for that in the final set of indicators.
And we're looking for family violence too.
Dushanka, I'm trying to move us. Go ahead.
I basically just wanted to say that from a Healthy People Initiative point of view, the audience is the nation, right? We're looking broadly at policymakers, the public in general. And so what we've heard here and what we are probably going to continue to hear is that at the ground level, everybody wants their own data for whatever purposes that they have and their needs. So the need for data, whether it's perceived or actual, the demand for data is great. I just wanted to add one point that Tom mentioned in terms of the education and exchanges that you have with state health directors. One of the points that we saw within our own discussions is the need for a stronger public health infrastructure and understanding what the emergence and the breadth of data that are available, what they mean, how to communicate it, how to use it. And so within that context, having the training of those communicators as well as having the data that are developed communicatable and simple and actionable. So just
one last question from me. My career has focused a lot in the private sector in terms of providing care to strata of the population, not geographic. Our conversation today has all been about geography in terms of geographic units of population. And I am struck by some analyses I've done about the marked disparity along multiple dimensions among, say, Medicaid and Medicare populations as opposed to privately insured populations. And since the government is providing healthcare services through the federal and state levels, as well as the structure of our private market, regardless of what we think about that structure, would it be useful to begin to think about not only looking at geographic sorts of organization of data, but systematically looking in these objectives about the differences between those sort of administrative groupings of strata of the population in terms of both the rates as well as objectives and so forth. How should we think about that?
So we did exactly that for the the data dashboard we created for Santa Barbara Cottage Health. So we have all the indicators. You can have them by race and ethnicity, but you can also have them by exactly as you say, if the person has Medicare or not, private insurance, just different things. And then we have things like gets enough physical exercise or physical activity, or eats 5 vegetables a day or whatever. We, to the degree we could, we presented the data that way, as well as by geography and by race and ethnicity.
To further amplify my question, that a lot of the policy levels are organized that way by virtue of the fact you have Medicaid directors and that kind of thing, as well as Medicare kinds of organizations. But other responses on that question?
We have not looked at it that way. We've thought about it. We have not explored into it. But I think you bring up a very good point. Traditionally, people look at insured versus uninsured, and that's really not the dividing. That's one dividing point now. But there's level of insurance underneath that. And that should be a variable that you could disaggregate on some way. So we have not, but great idea.
Marjorie, any comment?
I think that's a wonderful question. I also appreciate the potential opportunity in calling it out, the level of insurance. And I think my mind, the counter argument in my mind is reverting back to a conversation about health being health care, and the unintended interpretation of that stratification being that if only we just gave people health care, we would have healthy communities. And reverting back to, or trying to continue to bust up the myth that it is just about the doctor's office and truly that place matters.
You're right about that. There's a tension between those issues, but room enough in all of those approaches to figure that out.
Just sort of a quick warning.
Go ahead.
During the controversy over the ACA, there was a op-ed in the Wall Street Journal written by Scott Gottlieb, our now former FDA commissioner, saying, why should we expand Medicaid? Look at the people who are receiving Medicaid. They're in much worse health than the rest of the population. Like, why would we ever want to do that? And so that's kind of the risk when people are eligible for Medicaid on the basis of health. And you stratify, you tend to find, it's just sort of again, thinking about the crowd, who is your audience here?
You have to be smart about these things, but then that sort of argument can be made by any way you cut the data, depending upon how you feel about, those poor people in that particular neighborhood, for example. Anyway, so with that, let's take a 10-minute break.